Hi, my name is Dr. David Rubin. I'm a professor of medicine and chief of the section of gastroenterology, hepatology, and nutrition at the University of Chicago. Joining me today is Uma Mahadevan, who is professor of medicine and co-director of the Inflammatory Bowel Disease Center at the University of California in San Francisco. Today, the title of our program is The Evolving Treatment Paradigm for Ulcerative Colitis, New Approaches for Attacking the Disease. We're going to be discussing some of the novel therapies that are in evolution and that we anticipate will change the way we manage ulcerative colitis. We'll also cover some of the other changes that have occurred in the thoughts about how to manage this chronic condition. First, we want to acknowledge that the epidemiology of ulcerative colitis has changed. This condition, which was thought to be really reserved to westernized nations, has now been recognized as truly a global phenomenon. Ulcerative colitis has been rising over the last 50 years in the United States and throughout North America, and although it may have leveled off in its incidence and its growing prevalence, the area of the world that seems to have the fastest growing number of patients with ulcerative colitis is the Asia-Pacific region, which is noticing a dramatic increase in new cases of ulcerative colitis for reasons that are not known, but there are a number of theories. There have also been some changing goals of management. As with Crohn's disease, the management of ulcerative colitis has moved from more crisis management and predominantly symptom-based care to the recognition of the importance of achieving deeper levels of control. This includes, of course, that patients feel better, but also adds the recognition that healing of the bowel and other objective measures of disease control are associated with preferred outcomes, including reductions in disability, hospitalization, and surgeries, which are, of course, very important. In order to have adjusted our goals in this manner, we had to have therapies that could achieve such goals, and we'll be discussing that briefly today as we go through some of the new therapies and the evidence that supports them. So this has actually been a very important change in the way we think about managing these conditions, and rather than waiting for patients to call us when they're flaring and doing poorly, we really encourage them to have healthy visit checkups and to move through therapies in order to achieve these preferred outcomes. The FDA has recognized this as well and has proposed a number of shared or combined endpoints that include both patient-reported outcomes, which are symptoms, as well as these deeper levels of control, including mucosal healing, and has even expressed an interest in understanding whether histology, what biopsies show, may be a preferred outcome in managing patients with ulcerative colitis. The other change that has occurred has been the evolution and the development of new therapies that manage this condition. So the newer therapies for ulcerative colitis that are already FDA approved and which we won't talk about quite as often today will be listed on a subsequent slide. But the increasing number of therapies available to us have really adjusted and provided us with new ways to keep our patients well. The subsequent use of these therapies has now been associated with some changing outcomes. We've recognized that the number of patients who need surgery has been on the decline, which is probably a direct result of the available therapies achieving better control of the disease. It may also be due to a changing type of ulcerative colitis, which is not quite as aggressive, certainly in some parts of the world that has been proposed. Another change in the outcome has been the recognition that the rates of colon cancer, a feared outcome of chronic ulcerative colitis, seem to be decreasing, and we acknowledge this to be associated with preferred and appropriate management of the disease, control of the inflammation, better surveillance techniques, including the advent of some of our higher resolution scopes, and when appropriate, chromoendoscopy. And we've recognized that we're finding cancer in its earliest stages or even precancerous changes and contributing to prevention of these conditions. It may also be related to the fact that we do send patients with the more active and resistant disease to surgery earlier. So for whatever reason, the outcomes in ulcerative colitis patients continue to look better and better. The last point that should be made is that we've come to appreciate in all of the areas of inflammatory bowel disease the risks of chronic steroid exposure. And as we've gotten better at understanding how to use steroid-sparing therapies, we've also seen an improvement in outcomes. The current medications for ulcerative colitis can be divided into a number of specific classes. Of course, the foundational therapy for mild to moderate ulcerative colitis have been the mesalamine and sulfasalazine therapies and their derivatives. These therapies, of course, have been shown for many years and are some of the oldest therapies we have to treat ulcerative colitis. For disease that's resistant to these therapies or is more severe, We then move on to immune-based therapies such as corticosteroids, immunomodulators, and biological therapies. The steroids have evolved in their use not only from the understanding of how to use them in shorter intervals and to use steroid-sparing therapy, but also with the advent of budesonide-based therapies, both oral budesonide and a rectal formulation of a foam of the budesonide. Recognizing that budesonide has a rapid first-pass metabolism and less systemic side effects has led to preferred outcomes in the patients who respond to that strategy, and it has been proposed that using the budesonide formulation of steroid would be preferred before getting to systemic corticosteroids. The immunomodulators include the thiopurines, azathioprine and 6-mercaptopurine, and then we can move on to other such therapies like the calcineurin inhibitors, both cyclosporin and tacrolimus, which do have a role in selected patients and usually at centers with experience using those therapies. And of course, the other revolutionary change in managing ulcerative colitis was the recognition we can use anti-TNF biological therapies and more recently anti-integrin therapies. Biological therapies, of course, are proteins that are designed to target specific components of the immune system. We have 3 available anti-TNF therapies that are approved in the United States for moderate to severe ulcerative colitis: infliximab, adalimumab, and golimumab. And we have the newer class of biological therapies, the anti-integrin therapies, and at the current time there is a single anti-integrin available for moderate to severe UC, that is vedolizumab. This has a different mechanism that Uma is going to talk to us a little bit more about.
Let's look at some of the potential novel therapies that are coming up, and these are multiple different mechanisms, which is very exciting. Going along the vedolizumab pathway, one of the first mechanisms that's being studied for multiple agents is blocking integrins. So there's anti-MAdCAM 1, etrolizumab, AMG 181, among others in this category, and we'll be seeing a cartoon of how those work. There's also Janus kinase or JAK inhibition, the first one of which is Tofacitinib, which is currently FDA approved for another indication, rheumatoid arthritis. A novel mechanism is sphingosine 1-phosphate inhibition, which is ozanimod, currently in clinical trials. And then, of course, fecal microbiota therapy, which has gotten a lot of attention in the lay press and is currently the subject of multiple trials as well, both as enema, colonic infusion, and even oral capsules. Agents that are currently in trials for Crohn's disease, such as anti-interleukin 12 and 23 and SMAD7 antisense agents, are being considered for trials in ulcerative colitis, though those have not started. So this slide here looks at the mechanism of adhesion molecules. So remember, vedolizumab is an anti-integrin therapy. There are alpha-4 beta-7 integrin in the gut on T lymphocytes, and if you block that, you can block the cell attaching to MAdCAM, which is on the lining of the endothelium, and that's how these T cells get from the endothelium into the GI tract. So if you block either the integrin or the MAdCAM, you can then prevent white cells from going to the gut. That's how vedolizumab works, by blocking alpha-4 beta-7, etrolizumab by blocking the beta integrin, and then the anti-MAdCAM by actually blocking the MAdCAM itself. So let's look at some of the data here. So for anti-MAdCAM antibody, this was called the Turandot study, and this was in moderate to severe ulcerative colitis. In this randomized controlled phase 2 trial, they looked at multiple different dosing regimens to see if it would be effective. 3 doses were given at 4-week intervals, and at week 12, they looked at clinical remission, defined as a Mayo score less than or equal to 2. And you can see to your right that clinical remission was superior in the 7.5, 22.5, and 75 milligram dose, with the 22.5 milligram dose being having the best numbers, with a 16.7% remission rate and then 27.8% mucosal healing rate. So all doses showed a drop in fecal calprotectin, while placebo did not. And this will likely go on to later stage studies.
So Uma, this particular study shows one of the areas that we've discussed briefly, which is the importance of deeper levels of remission. And I think we are seeing now in all of the clinical trials, even at phase 2, that investigators recognize the importance of showing more objective measures of disease control as a way to confirm that we're truly controlling the inflammatory component of the condition. So here you see mucosal healing, but they also used a surrogate marker, fecal calprotectin. Are you using fecal calprotectin in your current practice?
Yes, we are using fecal calprotectin quite a bit, and often I like to tag it to a colonoscopy. So if I'm doing a colonoscopy on someone with active disease, I'll do a fecal calprotectin as well, and then follow that marker in the same patient to see if it normalizes, and then if they become symptomatic, to see if it goes up. So we use fecal calprotectin quite a bit. It's also a good test in somebody interested in getting pregnant, where we'll do a scope and a fecal calprotectin, confirm remission, and then if symptoms recur during pregnancy, we will see if the fecal calprotectin changes rather than scoping them.
That's similar to our approach, and I want to emphasize to the viewers that getting a baseline fecal calpro before you make a therapeutic change or decide on other management is really important, because if you get it in a vacuum, you may not know where it's going and what the trend is up or down. So I found this to be useful, especially in ulcerative colitis, where it's highly sensitive, less specific of course, but very sensitive for inflammation. All right, well, let's move on to another therapy.
So etrolizumab is currently in phase 3 trials. This was an earlier study that looked at this beta-7 inhibitor, and again, you see a 20% rate of clinical remission at week 10, which was statistically superior to placebo. And this was just looking at 2 different dose groups. So the 100 milligram group did better than the 300 milligram group. And this is, again, another example of inhibition of lymphocytes getting to the GI tract.
Why do you think the lower dose did better than the higher dose?
So we see this a lot in clinical trials. We saw the same thing in the infliximab trials. If you remember, at the onset, the 5 milligram dose of infliximab was better than the 10 milligram per kilogram dose at the beginning. And it may just be an issue of saturation of receptors. Once you find that point, giving more drug doesn't necessarily make it better.
Yeah, I think that's the right explanation, or at least the theory, and we've seen that even with 5-ASA. When you treat mild ulcerative colitis with mesalamine, higher doses may have more side effects than clinical benefit, and then you get confused a bit with some of the outcomes that you're measuring. So we certainly see that. So now that we're looking at a few of these anti-integrin therapies that are more gut selective, where do you think they'll be positioned or should be positioned in the management of ulcerative colitis? We currently have one of these, vedolizumab, that's available for our use.
So I think that these agents, at least in theory, may have a slower onset of action, because you really need to stop the white cells from going to the gut, and it takes a while for the turnover. So in your outpatient with moderate to severe ulcerative colitis, I think this is an excellent first-line biologic if all of these are effective, and certainly for vedolizumab. It's also a great agent for patients who are at higher risk for infection or malignancy. So for example, in my younger patients and then in my older patients where I'm going to use monotherapy, for example, in people over 60 or 65, this is a really good option. And in people with a history, for example, of various cancers, this may, in theory, be a safer agent as well.
Yeah, I agree with that comment, and I would just add that the choice of organ-selective therapy before systemic therapy goes along with what I said about budesonide, but it also mirrors what our oncology colleagues are doing to treat cancers. The more selective we can get, the better we might be. The question, of course, gets back to whether or not we think that some patients' IBD is more of a systemic disorder and they may have other problems. But so far, we haven't seen a dramatic rise of those types of issues with our use of vedolizumab, and I think the further investigations of these therapies will tell us more.
Right. Okay, so changing mechanisms here, we're going to look at tofacitinib. As I said, tofacitinib is FDA approved for the treatment of rheumatoid arthritis, and it is an oral Janus kinase inhibitor. It inhibits JAK1, 2, and 3, but may preferentially inhibit JAK1 and 3. And what happens when you inhibit that is you block phosphorylation of STAT, and then you have a downstream effect on all the cytokines listed on your right there. And so this is an agent that is effective, again, in a completely different mechanism of action. And what's unique about this is that it's oral. So there's no shots and no intravenous infusions. If you look at the clinical trial data for this, which was recently presented, the phase 3 trials, Octave 1 and Octave 2, you see that patients who were randomized to 10 milligrams twice a day were more likely to achieve clinical remission than placebo, 18.5% in Octave 1 and 16.6% in Octave 2. And again, this primary endpoint was clinical remission, defined as a Mayo score less than or equal to 2. Now, we do have to be cautious of side effects. There may be an issue with liver enzymes and with LDL in patients. But again, if patients have the option of an effective oral agent, that certainly will make it easier to reach more patients.
And most recently, the phase 3 maintenance data for this agent have been shared, and we know that they also demonstrated benefit over time. One of the challenges we've had to using this therapy before it has its regulatory approval has been the understanding that it's currently approved for rheumatoid arthritis at a lower dose. So when we do have it available for ulcerative colitis patients, and we hope that that will happen soon, we will be using a higher dose, and we think that that certainly for induction, as seen in Octave 1 and Octave 2, makes good sense. So this is of interest, a novel mechanism. Where might you position a therapy like this one, Uma?
So, one of the other things I wanted to point out in the trial that was unique to this trial is that it was similarly effective in both anti-TNF naive and anti-TNF exposed patients. And that really is unique in clinical trials, as usually we see better efficacy in the biologic naive patient, again, emphasizing the fact that this is a different mechanism of action. The fact that it's a oral agent should make it, if the efficacy holds up, which it has, and if the safety holds up, it may be your first line as steroid-sparing agent and first line step-up agent for patients who would require a immunomodulating therapy.
It's also interesting to see that maybe because it's a small molecule and is absorbed through the small intestine, it doesn't seem to have much variability in its absorption, and therapeutic drug monitoring with these doses and the pharmacokinetic studies don't seem to suggest we're going to need that. So I think this will be quite interesting and hopeful for our patients.
Yes. Okay, so yet another oral molecule. So I think it's exciting for patients that maybe we're getting away from injections and IVs, which for some patients mentally can be a stumbling block to starting therapy. So S1P1 or sphingosine 1-phosphate inhibition is a new mechanism of action, and ozanimod is the agent that does this. And what happens is by blocking S1P1R signaling on certain lymphocytes, CCR7 positive lymphocytes, which are central memory T cells, you can keep those lymphocytes in the lymph nodes and prevent them from going out into the gut. So similar to the anti-integrins, you're preventing the white cells from going to the gut, but this is in a different way. And importantly, protective immunity is preserved because those are CCR7 negative lymphocytes, which are the effector memory T cells, and those are not impacted. So the data here is very exciting, and phase 3 trials for this agent are underway. But in these earlier trials, it showed that it induced clinical remission, clinical response, and mucosal improvement in patients with ulcerative colitis. And you can see to the left that they looked at dosing of placebo, 0.5 milligrams and 1 milligram, and 1 milligram was the superior dose. And you did see a good response, again, as you mentioned, with more objective endpoints such as mucosal improvement and Mayo score.
So another mechanism for us to think about. Any thoughts now about where this drug might get positioned if it goes through its phase 3 trials and shows benefit?
So I think, if I were a patient, I think oral therapies would be something that would be appealing. And so, again, it depends on the efficacy and the safety. And I think if all of these agents come to market, that's great for patients because not all patients are the same and there are different mechanisms that work for different people. And what we as IBD physicians need to figure out is, can we predict who's going to respond to what mechanism and uh, tailor the therapy to that patient?
Yeah, I agree. I think we're in desperate need of biomarkers that are predictive of response to specific mechanisms so that we aren't just trying whatever therapy the payer lets us try or whatever therapy's next in the list that we have. I think that without that, we're going to have all these options and it's going to be like spinning a roulette wheel to decide what we choose. And although we certainly want to incorporate patients' preferences, we also need to be thinking about the mechanism and trying to understand the disease better. Often we say that ulcerative colitis is more homogeneous than Crohn's disease in terms of its behavior and its appearance, but we've come to recognize that even ulcerative colitis has some heterogeneity in its onset, in its behavior, and presumably in its mechanisms. So if we can start understanding better which patients will respond, and just as importantly, which patients won't respond to specific mechanisms, we're going to be in better shape as it comes to choosing these expensive therapies for our patients.
Correct. And this is just showing the trial data for ozanimod in moderate to severe ulcerative colitis. And you can see that for clinical remission, clinical response, and mucosal healing, that it was superior to placebo. And here we see that zero point 0.5 and 1 milligram looked variable in terms of the fact that zero point 0.5 was better for remission and 1 milligram better for response, and they were equal for mucosal healing. So I think the proper dose is still to be decided here. And what was very exciting is that as we start talking about deep remission, what does that mean? Does that mean endoscopically everything looks normal? From a blood serum standpoint, inflammatory markers are normal? Or can we actually change the histology? Can we heal the evidence of ulcerative colitis on biopsies? And here, ozanimod showed histologic improvement with 1 milligram versus placebo. And that's something that we see with other agents as well. And that is an important key because if we can heal not only endoscopically, but histologically, can we achieve deep remission and really change the outcomes of this disease for our patients?
So histology is of great interest, and although everyone thinks that the deeper you look, the better you can be, we need to recognize that we're still not fully understanding how histology can be used effectively. In other words, how many biopsies do you need? Where should you biopsy? Even though we think of the disease as being more diffusely inflamed, biopsies reveal a little bit of heterogeneity in the amount of inflammation. And what's the time course for histologic improvement? It may be different than endoscopic or symptomatic improvement. So there's some unanswered questions about histology, but I agree with you that the results of this therapy and using histology as another endpoint are very interesting and hopeful.
So now we get to a fan favorite, fecal microbiota transplant. I think every patient at some point has either thought about this or asked their physician about it or looked at it online. And what fecal microbiota transplant involves is taking the stool from a so-called healthy donor and putting it in an affected patient with various diseases. And since ulcerative colitis is in the colon, it seems an ideal disease to try this on. And this was a randomized, double-blind, placebo-controlled trial of multi-donor FMT, so the stool came from multiple people. And this was done in Australia. And on day one, they did a colonoscopy where they infused fecal matter throughout the colon. And then they asked the patients to do 5 enemas per week for 8 weeks. And they looked at the primary endpoint, which was steroid-free clinical remission and endoscopic remission or response based on Mayo score, and looked to see how these patients did. And what you see is at week 8 is that there was a significant difference between the patients who got FMT, which was 26.8%, and placebo patients, 7.5%. Compared to placebo, FMT led to higher rates of clinical remission, clinical response and endoscopic response, but not endoscopic remission. So though they made their primary endpoint, which was steroid-free clinical remission, it's important to point out that none of the patients who were on corticosteroids were actually able to get off of them. It was just there are more patients not on steroids than not. So it's a statistical issue, but the issue of steroid sparing still needs to be addressed. But this is a promising therapy, and I think it'll become a lot more palatable to people if the oral capsules are effective and come out.
So this has been an area of great interest, as you mentioned, based on the idea that the inflammatory bowel diseases have been recognized for many, many years to have a change in the composition of the microbiota of the gut. So the idea is, can you reboot that system by putting in healthy flora, even if you don't know what those flora really should be? So I am enthusiastic about this, but this is a pretty intensive study. As you noted, multi-donor stool specimens, enemas every day for 8 weeks with a couple weekends off. And the reality is that it didn't achieve our hardest endpoints, but I really view this as being informational for the development of more directed microbiota therapies in the future. What we really want to start understanding is it that the microbiota changes and that's what triggers relapses in ulcerative colitis? Or is it that there's some immune phenomena and then the microbiota change? So if it's the latter, it may be better to pair some kind of microbiota manipulation with an immune strategy. So maybe what we'll see in the future when we understand this more will be that we use something for induction of control and then we monitor and manipulate the microbiota for a stable maintenance. And that's a very exciting prospect. So the investigators who did this monumental study certainly will give us more information as they start analyzing all the data that are downstream from all this. So today we've talked about a lot of new therapies and we've covered some novel mechanisms. I think it's a very exciting time for our patients and really for us as the clinicians who take care of them with all the options we have, with the recognition of the importance of deep remission and achieving better control, with the recognition that colon cancer rates are decreasing, not because they're just going away, but because of the work we're doing. And I know that we have a very exciting future ahead for our patients, but we're going to need to think carefully about which therapies we can use and how we're going to sequence them. I want to thank my co-presenter, Uma Mahadevan from UCSF, and I'm David Rubin from the University of Chicago. Thank you for joining us.
Thank you.